Good evening, all. Welcome to the 12th edition of Teams Medalogs. And today we have another distinguished alumni from our college, Professor Jagdish Chandra Bose. And I request our esteemed professor, Dr. Ambuja Madam, to introduce Dr. Bose to the audience. Madam?
Yes, sir. Thank you very much, sir, for honoring me to introduce Professor Jagdish Chandra Bose, affectionately called as Jagan by his close and Bose. It has got its own story why he has become Jagdish Chandra Bose has become. And to introduce him to the audience, it's only a formal one because he is known to everyone in India and abroad. He has become an international oncologist, right from Tanjavur Medical College as a MBBS student, with the proud parents, Professor P. Soundararajan and Madam Saraswati. And he continued to be the best outgoing student in MBBS. One small thing is his name will be the attendance, Jagdish Chandra Bose. Jagdish will be marked as absent. Chandra Bose will be marked as present. And Professor Ratna Subramanian came for a, annual day and convocation day. He was introduced as a blue-eyed boy, and this was quoted by Professor K. A. Kishore, anesthetist. That was then when he became as a Bose, and probably there is no mistake. He is a blue-eyed boy of Tanjavur Medical College alumni and MBBS, MS by the great giant Professor S. Venugopalan, trained by him and all aspects. He continued to be his postgraduate. Then he was a medalist. All these things are known to all of us, and more than that, whoever has spread across the globe knows Bose very well for his attitude, commitment, and concern, care, with love and affection for the patient.
But
But
we
at the
had
same
courage
time,
also, madam.
sir,
Had courage also for a surgeon.
courage and how he deals with the caretakers of the family members, it's entirely different. So that spade is a spade, he will say, and you can't deviate. This is opposite of Professor PSR, because he will be very kind, delicate, he will be very strict and stubborn, and he continued to be there like this. The one, as I said earlier, before introducing to all the audience, he worked after his post-graduation in Tanjavur Medical College to start the department as a surgical oncology, and he was not given any ward, any unit, but he was attached to radiology department, worked with Professor Sivakulundu, and he was having one ward. No PG, no CRRI. He used to start the chemotherapy and take care of the patients. That much of commitment, no pay. He was not paid by the government because the post was not there. No pay for nearly a year. Then only he moved to Chennai, which has made him to be the, I think after his training in the Cancer Institute, he came as, he could not start the department, only one ward and the radiology department, and all the time with the patients, spending all the time. With the kind courtesy of Professor Venugopalan, he was attached to that unit to operate, not only in his unit, he will operate for everybody for an oncological services. This is what he was doing, and all of us know about Bose, what he does now in after being an MMC, and then after retirement, he was in Tanjavur serving for some time. Then he joined the great institute, Ramachandra Medical College and Research Institute. as professor and head of the department of MCH. He has got a very good friend, medical oncologist, Professor Mch ONCO. Now, even now, he continues to be very strict, and the guidelines given by Professor Bose had to be followed. Even if he comes out, this is different. This and one more thing I would like to add about Dr. Bose, his commitment to the patient is, and the teaching, academic, research, all the wings he will cover as far as the oncology, especially breast. He was in the team when I was in Nayaga Missions Medical College. He was on the team with the UK, Professor Narayanan and other things, as he was mentioning. And he continued and took class for the postgraduates as well as the faculty members or PMMC, Nayaga Missions Medical College, Karaikal, every second Saturday, every month, and the breast care training program. To conclude that at the workshop, he came all the way from Chennai for 3 days, leaving everything for hands-on training and breast, how to breast conservation and everything. He was staying in there, teaching the postgrad. That much of passion he has got for the patient. And why I am telling, he has included gynecologists also in this team, because most of the things I usually comment the breast, because babies are feeding, everything they take it as a consideration for a malignancy importance. It has to be proved otherwise. That he will tell and insist with a strong words to the obstetrician and gynecologist, that everyone can appreciate. And there are a lot of things about Bose to talk. He has got a palliative center. He cares for the patient. The patient as a whole to be treated. No steps to be missed. Either it is a chemotherapy, when it is switch over, all these things. And I think whoever is logged in or whoever is in the team case conference, this thing goes for the credit goes to Professor Captain Sir for having formed all these things, having taken Tanjavur Medical College Alumni Association, making this a strong forum for teaching the postgraduates, training them, talking about this research, publications. Yes, incorporated so many things, and that is why today it has become Dr. Bose Day, and we will continue to speak about him any number of hours. But now we would like to hear from him about the cure, relief, and comfort for the cancer treatment. Thank you, sir, for the opportunity to give a. So we will hear from him.
Shall I start, sir?
Okay. Yes, sir. Yes, sir. Please, sir.
Madam, thank you very much, madam. It is a great honor to hear such words from you. And
I am honored. I am honored to.
No, madam. I want to say only one thing. Like, what I am today is because of my teachers, like you. And I know Captain Sir is also watching this. I wouldn't be here today because without my teacher, Dr. Venugopalan, and the other people who had taught me all this from the Cancer Institute as well. Now, I was really impressed by the topic which was given for me, like cure, relief, and comfort in cancer treatment. When Dr. Venkatesh called me and said that this topic was given by Dr. Murali, I was really impressed. And I went on dissecting this topic for a very large extent, and with my students as well. And this talk is going to be something which is totally non-scientific. You can take it that this is going to be a very non-scientific talk predominantly. I'm not going to go into all those details of treatment and all those things. So let me start this talk. And I wanted to say that this is going to be my own vision of what cure, relief, and comfort in cancer treatment is going to be. And I will make it very short. Now, sorry. Okay. So the disclosure here is these are some difficult lessons learned from my patients, to whom I am really thankful, because without them, I wouldn't be talking to you today. And I thank my students for helping me to prepare this talk, because there are a lot of inputs from them, which I'm going to share with you. Now, the outline of my talk is going to be the title dissection, which was very interesting when I went into this title. And then about the tumor kinetics, and something about treatment decision, how to take, and the lessons learned. The lessons learned will be divided into cure in stage 0, relief in cancer breast, comfort, resign, conclusion. This is how my talk is going to be designed. Now, to go back to this interesting topic, cure sometimes, treat often, comfort always. This was none other than Hippocrates. Cure sometimes, to relieve often, and to comfort always was the next one. Now, I just went into the literature to see what is there to offer in this particular topic. It is very interesting that it went through the 16th century by a French guy called Ambrose Paré, and then followed by William Osler, and finally Livingston Trudeau in the 19th century. This particular topic has been of interest in all these centuries, and we will tell what it has got in this century as well. Now, there is an interesting paper, if you browse into this, to see cure, comfort, and relief. Here, David Wright adds what is called as resign to this particular paradigm. In 1985, this guy adds another thing, and you would see the importance of this. So he took 200 patients and found out, as a physician, how many of them are likely to get cured, and that will be 11 of them. And relief was in 69. Comfort he could give for 113 people. And he said, I was not able to, and I had to take a defeat in 7 of 200, where I had to resign. And I had to say that I could not offer these 3 for the remaining people. Now, what do you refer to cure? A cure refers to the treatment that completely resolves a health problem or a disease with expectations that it will not recur. And it is the ultimate goal of any treatment, leading to the patient's complete recovery and restoration of health. This is what is defined as cure. Now, what is cure in cancer treatments, which happens sometimes? In 18th and 19th century, cure in cancer was complete removal of macroscopically visible tumor, or to achieve what is called as a complete remission. In 20th and 21st century, the cure was with better understanding of the biology of the tumor, and it moved from a radicality to minimal conservative approaches. The cure in cancer is defined as a 5-year survival, and with cancer prognosis, we know that if a patient lives for 5 years, almost 90% of the time he is cured, and that relates to the general population. The most wanted word in cancer for every person is cure, and that gives him a lot of mental relief and comfort. Now, what is relief in cancer care? The relief denotes temporary solution to the problems and a mental satisfaction, that pain, bowel, bladder obstructions are relieved, and sometimes even no surgery gives a relief. As in advanced disease, we know that patients seldom benefit with your surgery. Patients relief from physical and mental symptoms, which are the most first priority, and not what the doctor thinks or wants. It is not as per the doctor's decision that you get relief. It is what the patient wants that gives him the relief. Now, what is comfort? The comfort is being there with them till the end. Support and confidence in the journey, non-abandonment socially, physical and psychological aspects of care, helping them to do things that they can do in the best way possible, improving their quality of care and the activities of daily living. Now, this would definitely give any patient a good quality of life. Now, something about the tumor kinetics. So why do you need tumor kinetics? This helps us decide whether we have a patient with a curable intent of treatment, a palliative intent, or with a symptomatic care. Now you know that the tumor kinetics tells us that the diagnostic threshold is 10 to the power of 9 cells, and whereas you lose most of the patients when the 10 to the number of 12 cells are reached. This amounts to just 10 doublings. From 30 doublings, when the tumor is seen or clinically detectable, you see that with 10 doublings, you lose the patient. Now, this doubling time really tells us what is the tip of the iceberg. Now, if you see here, this is the 30 doubling, which is the preclinical phase, where it is very difficult to make out the tumor unless the tumor secretes something biological, which is made out in the form of some tumor markers, or it should be an immunological way to detect them with IHCs and liquid biopsies. The tumor reaches a size of around 1 gram, which is around 10 to the power of 9 for you to detect it. And that is the clinical phase. And from then on, just in 10 doublings, it would kill the individual. Now, the act of your treatment is going to be as per what is called as the kinetics of skipper. We see whenever we give a drug or when we give radiation, we are going to use what is called as the first order kinetics of skipper. You're going to kill only a proportion of cells, thereby the cells decline and then they reach something like an area where it is immunologically handled by your body's own immunological responses. But whereas when you try to do a surgery, you do what is called as an R0 resection, that is by a zero order kinetics, where you try to remove the tumor completely. And so you can achieve this at a single sitting. Now, next comes this phase of what is called as elimination, equilibrium, and escape. This is not for cancer alone, it is even for chronic diseases, where you would see that your immunity is very important in controlling the equilibrium, where the diseases are kept in abeyance. When your immunological system fails, there is an escape of these cells and you get a recurrence. Now, what is the cancer treatment all about? The cancer treatment is about tumor elimination, and you get a cure, which is a long lifespan, where the patient can remain in remission for a long time and then they can relapse. Or you can have resistant clones which can mutate and relapse is possible. And they can have a metastasis. And when metastasis occurs or when there is a relapse, you know the prognosis is poor. There is also some problems with your treatment. You can have treatment-related side effects, which may be resulting in sometimes death. And so you need to monitor them very carefully and use it in the right patient. Otherwise, you may have serious adverse reactions or treatment-related mortality, which can lead on to death as well. Now, factors affecting the choice of treatment would be divided into tumor factors, patient factors, physician factors, and other factors. We would take head and neck cancer into consideration, where we would see the stage of the tumor, the location, the proximity to bone, the status of the cervical nodes, the previous treatment, the histology, the biology, and the molecular type would matter from the tumor factors. The patient factors, we take the general medical condition, the tolerance, the occupation, the acceptance, the compliance, the lifestyle, the socioeconomic considerations, the dental hygiene, the nutrition. The physician factors will include how good a surgeon is, the radiotherapy is rendered, whether chemotherapy is added on to that, your rehabilitation services, the dental, the prosthetics, and the support services. The other factors will include as complications, the cost, the convenience, the compliance, and the long-term sequelae. So we need all these factors to be taken into consideration before you decide whether your treatment is going to work for an individual patient. all patients do not have the same factors working in them. So you know the patient first, followed by a good multidisciplinary team. A shared decision is often required to take a good decision as to how to treat an individual patient with cancer to achieve your desired results. Now, the intent of treatment can be divided into three. One is the curative form, the second is a palliative, and the third is the best supportive care. Now, it is very important that you decide what is the intent of your treatment before you start your treatment. There is no point in trying to do this decision without a proper intent. This has to be a very shared decision with the patient and the relatives. There is no point in forcing some treatment into a patient where you have a small percentage of cure because of financial toxicity. Now let us go to the first lesson. Now there are some lessons which I've learned from my patients, which I would like to share with you. We have a young man who had a familial adenomatous polyposis. His father died of a colonic malignancy at 45, and the mother was an anesthesiologist with a strong medical support system. He had a twin brother who was negative for APC mutation. Now, he was diagnosed with familial adenomatous polyposis at 18 years. He underwent a laparoscopic total proctocolectomy with an ileal pouch at 2008. The final histopathology said that he had no invasive cancer and he was a stage 0 disease. This represented the cure phase of the treatment. Now we know that this patient is not likely to recur, and this was a prophylactic surgery. He went to US to undergo further studies where he was undergoing every year follow-up, and 8 years down the line in 2016, he was detected with an intra-abdominal mass, which was a fibromatosis or a desmoid tumor at the mesenteric root. He was opened and they could not do a complete resection. They could resect only a part of the tumor, and he was started on tyrosine kinase therapy. The post-surgery, he developed an intracutaneous fistula, and it was converted into a permanent ileostomy. So you can see here that even when cure is achieved, we know that complications can redefine the journey. So the next comes his further management, where he was stable with the disease and taking tyrosine kinase inhibitors. He adjusted to his life with a permanent ileostomy, maintained education and independence. He was embodied with the relief, managing disease while preserving function and purpose. The transition now comes when he develops a bilateral obstructive uropathy, and he has to undergo a DJ stenting followed by a percutaneous nephrostomy in 2021. And he is moved to palliative care for symptom management. He develops occasional intracutaneous fistula discharges, and he is on pain control, nutrition, psychological, and social support. Now the holistic care starts. We know this guy underwent a preventive colectomy to avoid a colon cancer, and now he has relief with disease control and tyrosine kinase inhibitors, and now comes comfort with palliative care to ensure dignity and hope. The continuum of care adapts to the patient, to the needs for the time. So the human spirit overcomes all this. Despite of multiple surgeries and stoma, he continued his higher studies in US. He is awaiting a multivisceral transplant. This is a symbol of courage, adaptation, and holistic healing. The healing is not just the same with curing. Sometimes it is able to find peace amidst pain. Early detection can change the destiny. Multidisciplinary and holistic care sustains life. Palliative care, leading a meaningful life with the role of family, medical system, and personal willpower will cope you and support you with good comfort. Now, there was an interesting question from the mother of this boy who asked me, "Sir, this guy underwent a preventive surgery. When he was 18, his father did not undergo. His father lived up to 45. He is struggling now. I don't know whether he will live up to 45. What did the prophylactic surgery do for my son? Is it correct that I did this surgery, or am I wrong?" So I was puzzled. I could not answer this question. I just gave her the comfort. I said, we hope for the best when we try to treat people, but we may not. We can change the destiny. But unfortunately, we are not able to do that in certain situations. The mother's question was very relevant because her husband lived up to 45. The son is not able to live up to that particular age, even in spite of this prophylactic surgery, which we deemed to be a cure for this particular boy. Now, the lessons from the breast cancer, which we learn. We have a young female who is 32, a mother of 2 children, hormone-positive breast cancer, and she was married, living with her husband and children, and her life transformed totally. She was a professor in an engineering college. She underwent chemotherapy. She was considered for surgery, and she went through all the side effects of hair loss, fatigue, and in spite of that, she maintained taking care of her children for the benefit of the children. Then she was started on maintenance therapy with tamoxifen. She continued to menstruate, so she was taken up for a laparoscopic oophorectomy. And then she was continued on hormones with the letrozole. So she started feeling that she has lost a part of her womanhood because of removal of the breast. She went through all these personal and psychosocial struggles where her husband divorced her in 2021. And due to long-term stress, I think probably she developed diabetes in 2022, 23. She had hypertension. And she thought she won the battle, but her marriage broke. She had a single parenthood taking care of the children. And the emotional pain, I think, overcame her more than what she was. In December 2024, she stopped letrozole because she has completed 10 years of hormone treatment. Unfortunately, in January 2025, the disease returned back. She had multiple metastases in lung, liver, and bone. And now the fear of treatment rose in her. She had to go through this time a HER2 positive recurrence where she was treated with chemotherapy again. So this started a new treatment phase for her with targeted therapy. And she was managing her comorbids with regular follow-up, and her priorities changed. Now the support systems for her are patients, groups, friends, and therapy to cope up emotionally. She lives a life of one day at a time, and this is the comfort she has. The lesson we learn with some of these breast cancers are living with metastatic breast cancer is a journey of ongoing decisions, personal agony, courage, support, understanding to make all the difference. So she says, cancer may have taken parts of me, but it gave me strength.
Sir, your slides are not moving, sir.
Oh, sorry. Is it?
Yeah.
Is it okay?
No, sir. You have to reshare it again, I think.
Now?
No, sir, it's not moving.
Okay. I'm sorry. I'll share it again.
We are in that slide where you have written worried about children.
Oh, right. I'll see that whether now it's coming back. Is it?
Yes, sir.
Yeah. Yeah.
This was there, right? Okay.
Yeah, these all you read out, but we didn't see the slide. Yeah, now it's okay.
This is fine. Okay.
Hmm.
So now she's on treatment with the targeted chemotherapy and endocrine support, and children are her motivation. And you would see here that she leads a life one day at a time. And what she personally feels is what she has recorded here. Cancer might have taken parts of me, but gave me strength that I never knew I had. My journey continues with hope, resilience, and love. So this is where you see a cure, which you think is cure, but it is actually a relief. And now it comes to comfort. So cancer care is not about just relief, resilience, and continuation of life. It is a holistic approach, integrates medical excellence, emotional support, spiritual well-being, and quality of life. Now we have a hereditary cancer, lesson 2. This is in the era of the BRCA gene, which started in 2015. We had a 55-year-old radiologist, a mother of 3 daughters, with a right breast lump. A strong family history of 2 sisters diagnosed with breast cancer. So after a triple assessment and workup, she was staged to have a T2N1 disease, which was triple negative. She was counseled to undergo neoadjuvant chemotherapy and a BRCA testing. She defaults treatment owing to her oldest daughter's marriage, and subsequently she went for child care, travels to US without any treatment. She reports 1 year later with a T4B-M1 disease, started on palliative chemotherapy, lived for a year, and passed away in 2018. The problem does not stop there. Her daughter is in US with her young 8-year-old daughter, wants to discuss about BRCA testing. She tests positive for the same and undergoes a bilateral prophylactic mastectomy with reconstruction because of the Angelina Jolie effect. She has 2 sisters who are pursuing the master degrees, who declined testing. They were counseled, but they declined testing. Now, what is this Angelina Jolie effect? We don't have Angelinas here, we have Angeli. The problem is our people do not take up counseling in a right way. It is their personal choice which trumps. And you see here, even though we have robust system to give them genetic counseling, it is the personal choice which really matters. There are pros and cons for and against BRCA. If you do a BRCA, your treatment alterations would be there. You have good options to have PARP inhibitors, a prophylactic mastectomy, or you can undergo even a high-risk screening. But what is against is that it is not feasible in a general population to be screened because it is very rare. You can do it probably in a high-risk population. There is always a social stigma that your family will be blamed as a cancer family. And of course, about the body image and a lack of complete elimination of risk, even if you have a prophylactic mastectomy, that the onus of the gene may shift to another organ. Now, why BRCA testing is not very prevalent? There are various reasons. We have no definite demographics on Indian population. The lack of awareness, the failure to diagnose, disclose, ignorance, denial, as in this particular case, the lack of family support, And we don't have specialized genetic counseling centers for the public, and there is an absence of open dialogue with the community. So what is the need of the hour? We need all these 6 A's: accessibility, affordability, acceptability, applicability, adversity, and advisability. Then we come to the last lesson, where you have a comfort alone. We have a 55-year-old leading oncologist in the town, living in his own apartment with 2 daughters, a software professional, and another just finishing his studies. On routine master health checkup, he is picked up with a 4 into 3 centimeter mass in the pancreatic head and body, involving the uncinate process, which was deemed to be a borderline resectable lesion, and he was in good performance status. He was counseled for neoadjuvant chemotherapy and followed by reassessment for surgery. He was willing only for morphine as palliation, not willing to proceed with any scientifically proven treatment. He refuses to see his colleagues and friends, confining himself home, completely disconnected from social contact. Sold his own flat, got his 2 daughters married. After 2 years from diagnosis, develops shortness of breath, diagnosed to have metastatic disease, massive ascites, went for symptomatic care, happily passes away in a month's time at home with his loved ones. Now the agony is for the family. The family feels that he has ignored medical care. Denial and acceptance or individual rights. Denial is typically the early response of all cancer diagnosis. Educated patient, as in this case, may weigh the medical evidence of complications related to the treatment. Some prioritize quality of life over quantity of life. Some are self-directed, preferring meaningful living with dignity than enduring treatment, which is perceived as futile, burdensome, as well as financially. So addressing fear, denial, emotional response is the responsibility of a physician. State of coping. The impact of cancer on social connection is that most of these people at initial diagnosis or during active treatment try to get more isolated. And when the treatment doesn't work, they get their anger on the caregivers, which including the doctors. So psychological counseling and therapy sessions are mandatory whenever you have such patients, when you want to take a shared decision. The state of hopelessness or helplessness with diagnosis of limited curative potential cancer, where cure is unlikely, where patient may feel the efforts are futile, leading to withdrawal of treatment or options and finishing their personal commitments, is again a family decision which had to be made, and it has to be encouraged in open conversation about the priorities and reassurance of care. So the disseminated treatment disease transition of treatment focus from cure to comfort is not a failure, but a compassionate response to patient's reality. Integrated palliative care improves quality of life, decreases hospitalization, and supports the family. So all these require open conversation with end-of-life care. So thoughts we need to take are the importance of patient-centered care, involvement of patient and families with the decision, addressing denial and fear. The shared decision-making is a priority. It prioritizes dignity, autonomy, quality of life, symptomatic relief of incurable diseases, palliative care focusing on holistic approach, physical, social, psychological, and spiritual, encouraging open conversation about priorities, fears, and end-of-life care is important. Now, perspective of cure in cancer most often relates to fear of recurrences, early death, or short lifespan. Disfigurement during treatment, surgery gives you mental and social agony. Seeing people suffer or die, and what really disturbs them is the hope of miracle or a percentage of survival, which may get some people trapped into unnecessary, unwanted treatment. Truthfulness of information, though truth would hurt sometimes, but it will win the trust of the patient. What we think we become is a strong saying that works with us to make us achieve what we want. What is the perspective of dying? If given an option on what type of death, how somebody would want to choose, in a mixed group of people, including doctors, psychologists, what most of them preferred was a sudden, unaware death. And the next choice was a silent, aware death at sleep, home, and hospital. And what least preferred was with a good palliation, saying goodbye to the loved ones, because nobody wants to face the reality. The art of dying is often affected by consumer-driven care, technological advances, and societal shifts. So it is often that we see that we deliberate sometimes, choose often, but consume always. This is what we face when it comes to dying. So what is the conclusion is we need to revive the forgotten wisdom. Patient-doctor relationship is often sacred, and it is a promise of agreement, which is considered as convenator. Doctors' responsibilities are with trust, which is with a good fiduciary, and it should be always non-financial. The points to ponder about cancer care is that fighting reality and nature, which is the biology of the disease. And cancer is basically considered as a natural calamity in the body with mutation and failure of apoptosis. We are fighting a war or waging a war against nature in evolution. From everybody wants to be immortal, but I think we are all programmed to die. I would say that cure, relief, and comfort are not stages, but dimensions of care. Every patient deserves all the three in different proportions at different times. Thank you very much for this wonderful topic and all of you to have listened to me for this nice lecture. Thank you very much. Thank you.
Thank you, sir. Thank you so much. Now the floor is open for questions and comments to Professor Bose.
I'm sure that this talk was a little different from what you would have expected, I think. But I wanted to share my views because these are all some lessons which I have learned throughout my career. And I felt that at some point of time, we need to understand that our technology cannot overtake everything. Thank you very much.
Thank you, Professor Bose, for really, you did 100 times more justice than what I envisioned when I thought about you as when I wrote the title of this topic. Because I knew, knowing your ethical values, you call a spade, you're always someone who balances science versus art of medicine, because we had several arguments in our case conference group. That's why I thought this will be the ideal topic for you. And you did wonderful justice to it. See, the different regimens or protocols we can read from textbooks, but to know wisdom from somebody who has had 4 decades of experience in this field, it was really wonderful. I definitely think that most of the audience would agree with me.
Thank you, sir, for the nice words. Thank you.
So there is a question in the chat box by Dr. Gokula Krishnan. He wants to know if the actual incidence of malignancy has increased or our diagnostic modality increased so that we are diagnosing more number of cases.
That's a good question, right? So I saw the Vice Chancellor of the MGR University in a talk said that it is actually the the diagnosis which is showing an increase. It is wrong. It's not so. Really, the incidence of malignancy is increasing, and we have definitive data for that. We are sure that the incidence of malignancy is increasing, and the role model is the breast cancer. I can quote saying that when I was a student, the incidence of breast cancer in women was 1 in 40. Then it became 1 in 25. In 2040, it is predicted to be 1 in 10 among the women who are going to lead a life which is going to be up to 70 years. So you can definitely say that the incidence of breast cancer is increasing, and you know that the breast cancer is the role model for all the cancers. Any solid tumor, we take breast cancer as the role model. And we know that definitely there is an actual increase in the incidence. So why so? There are so many factors. It is not a single factor which would cause the breast cancer. We know that genetic factors have always been remaining, but still, now we know that the lifestyle is the most important factor. So we have to understand that the cancer incidence is increasing. You can always say that how many hospitals have come up. When I was a student, I could see hardly a few cancer hospitals. Now you see the cancer hospitals are many, and every cancer hospital is full of patients. So there is no doubt that the cancer incidence is increasing, and we have to accept that. And I would say that breast cancer has become an epidemic now. So we need to really take some precautions. We need to address to it in a very, very big way. We are taking it very lightly. And I'm sure that the government should come up with some measures and should advise all the people to go in for some good exercise, avoid obesity, and take good pains to take care of themselves. Our women don't put themselves forward. They always think that the family is first. And that is one other reason why we have an increasing incidence of breast cancer. So we know carbohydrate intake is being implicated, and that has to be really cut down. In the Indian population, you see that carbohydrate intake is the primary reason why we are having so many breast cancers. And that is because of the insulin growth factors which is being initiated. So we have a large number of triple negative disease in the earlier ages because of carbohydrates. We often tend to ignore that. And that is why I would say that we need to really give an insight into our people as to what our diet should be. Thank you very much for asking this question. Thank you.
Dr. Bose, nowadays there are a lot of, being October month, nowadays a lot of screening programs are going on.
Yes.
It's just a namesake, or it is being done
Yeah.
and addressed?
Okay, madam. That's a very good question, because we have 3 types of screening. We don't do general population screening. General population screening in India is not there. It is not practical. So we can do what is called as opportunistic screening. For example, we have a patient who comes with a breast cancer. You can screen the family. That's called an
Yes.
opportunistic screening. And then the high-risk screening. High-risk screening is basically a good thing. Like, for example, if you see the BRCA incidence, the BRCA incidence in the general population is 2 to 3 per 1,000 persons. But if you take the high-risk population, you would see 10 to 20 of them. So there is a definite increase in the incidence of BRCA if you take the high-risk population. So you can screen the high-risk population. You can screen the people who are opportunistic. So these two itself will definitely bring down the incidence of advanced breast cancer. So there we are talking about early detection. I don't think early detection alone is important. We need to talk about primary prevention as well. The primary prevention is the most important thing. And that is what I was mentioning to you about, where we need to educate our women. We need to tell them that they need to do exercise. We seldom find any women exercising after 50 years. And when you tell them, they say that it's not my way of life. So we need to educate them on exercise. We need to educate them on maintaining their body weight, and we need to tell them that you need to attend to yourself. A lot of women don't attend to their mental health as well. They take things very easy. They don't sleep properly. So they are awake up to 11 o'clock, and then they get up very early in the morning. They don't attend to the diet properly. They take all leftovers in the home. And this is the primary reason why we are getting a lot of breast cancers now. So we need to really look into it in a very different sense. It is not like the West. We are not getting breast cancers like the West. No.
Cervical malignancies, aren't they the ones which are much more prevalent than breast cancers, sir?
No, sir. The cervical cancers have taken a second step now. See, what has happened is with the advent of good hygiene and with the availability of water, even the per capita water intake is related to the per capita water availability, is related to the incidence of cervical cancers. You would see that Kerala is the role model. In Kerala, cervical cancer is a notifiable thing. They will run after people if you have a cervical cancer detected. Now, the cervical cancer incidence in Kerala has come down to a very large extent. But in Tamil Nadu, it is not so. Why? Because we are taking things easy. But in Kerala, they are the role model of what is called as the community care. They can give a good community care, and they can emphasize on screening and doing pap smears to a very large extent to pick up all these people. So cervical cancer incidence has really come down. From when I was a student, when I was practicing oncology in 1990, I used to do wartime cystectomy that commonly. I think madam would know. Like I used to go to Vishwanathan Hospital and operate every week for a radical hysterectomy. Now radical hysterectomies are very rare. We do radical hysterectomy something like once in a month. We don't get cervical cancers that commonly now. But we do 4 or 5 breast cancers every week.
Every day.
Yeah. You can imagine the incidence of breast cancers now.
How is the vaccine uptake for cervical malignancy, sir? Has it dented the incidence?
Yeah, it has made a difference. It has made a difference, but it has to be given in the school-going children. Yeah, it has to be given in the school-going children. A lot of people are having some social stigmas about it, but we need to educate them. We need to give them. So I think the government is coming up with some good programs, and there are certain good organizations who are also taking it up, and it would definitely go a long way in preventing cervical cancer incidents. Definitely, yes. And I think it will come to the men as well, young boys, right? Because they say incidence of, oropharyngeal cancers, all that is on the increase in non-smoking young adults, correct? So we need to have it for the younger population of men as well, right?
As you have told, I made it a policy right from the beginning to examine all the ladies for whatever reason they come to me after 35.
Yeah.
I examine the breast. If I
Correct.
ask them to go to the examination table, they will laugh at me. I have come for fever. I have come for abdominal pain. Why are you asking me? I said,
Madam,
without
I
examining.
will quote one thing for you. I asked the convent mother superior to put a mirror in the bathroom. She said
Bathroom.
no. She said no, She told me I can't allow the people there to examine themselves in front of the mirror. It's such a pathetic state, right? Our women don't examine themselves in front of the mirror, right? So I asked the mother superior of our Tanjavur convent to put mirrors because I used to get a lot of breast cancer patients from the Tanjavur convent. So I went and told her, requested her, why don't you keep mirrors in the bathroom, right? She said, no, doctor, it is against our principles. So this is the answer she gave. You can imagine how a lady will permit you to examine her, right?
Both one doubt.
Yes, sir.
I hope if my memory is okay. Professor Radhakrishnan told me CS cervix never reported in Muslim women. Is it
No, 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 it's
80 or 81, I think?
correct. Sir, that was the wrong idea, sir. Like it was because they said that smegma in uncircumcised people, was the cause for the breast cancer. Sorry, the cervical cancers. But it's not true, sir. No, it's not true.
Okay.
You may say that maybe the incidence may be a little less, but it is there. We have seen a lot of Muslim women with cervical cancers. Yes.
Nice. I hope you remember when CA Cheek operated in Golden Rack Hospital.
Yes, sir. Yes, sir. I remember. Yeah.
That man lived for 40 years.
Okay, great, sir.
Settled his family and passed away only 2 months back.
Is it, sir? Nice. Cervical cancers are local regional, sir. You can win over them to some extent. Unlike other malignancies like breast, which can be sometimes systemic as well. So, convincing for pap smear. Any idea of convincing all your experience, even of the family? Yeah, okay. There is some question in which says convincing for pap smear and breast screening itself is a majority of task now, even in our family, some stigma. Any ideas of convincing on your experience? I can tell you that a lot of women don't want to have screening done. The reason behind that is they fear that something will be detected, and so they have to go for further treatment. That is the main reason why they don't want to go for screening. I would say that it is very difficult, even in my family, to convince women to go for screening. It's very, very difficult. I agree with this question, but it is counseling. You need to counsel them. You need to tell them what will happen if you have a breast cancer detected in an advanced stage. You can't conserve the breast. You have to lose your breast. You have to undergo chemotherapy. If you find it in an early stage, maybe you can avoid chemotherapy. You can avoid losing your breast. And that will give them the confidence to go for the screening. Now, it requires a lot of effort, and it requires an attitude from the individual to accept what we say. That's why I said coming to reality is a very difficult process in cancer. So whenever we see a person, we want to convince him for some procedure. Like, as I was putting some of the instances where somebody wants to say no treatment, we really discuss with them. We talk with them. We tell them about the cure rates. We tell them that this is an option you want to take. It is up to your priority. But there are some people who definitely say no. They are very clear. And the same way, like if somebody doesn't want a screening, we are not there to force screening into them. You can just advocate screening, but it is up to them to take it or leave it. So never force somebody into screening, because they are going to tomorrow blame you, saying that because I did the mammogram, I found out a cancer. And so it is very difficult for such people to get convinced that screening is useful, because we know that there are some studies saying that screening is not useful, right? So even in the Switzerland, there was a paper which was published saying that screening is not a useful modality. But I tend to disagree with that on one very important point. Screening is a modality which we need to follow meticulously, because early detection would save lives, would save the morbidity of the treatment, which nobody can deny. The morbidity of the treatment is very, very important. That is why this talk was basically not about cure, it was about relief and comfort. We are not talking about only cure, we are talking about relief and comfort as well. We need to have an individual who want to have a good relief and comfort. What if we are aiming only at cure? We are not aiming only at cure. We want a good relief. We want a good comfort, aren't we? We don't want to die in agony. We don't want to have a tormenting death. And that is the primary reason for screening. If somebody would agree to that, definitely they would have the screening done. And there is another question on lead time bias. The lead time bias is something which has been exaggerated by a lot of people. If you have 3 mammograms done in 3 consecutive years and they are normal, you can do it once in 3 years, because the biology of the disease which we are trying to detect is something which is slow growing. We are not interested in detecting disease which has a very short doubling time, that is not going to help anybody. So you're not willing to find out a disease which is going to have a short doubling time and trying to do exaggerated treatment or escalate treatment and trying to find out a big cure in such people. We are basically interested in finding out a tumor which is going to grow slowly. And those are the tumors which will benefit by your screening. So screening is required, and it is required in at least a good population where they have a higher propensity to have the disease. So how do we really screen them, or how do we really pick them out? We pick them out by having something called an opportunistic screening or a high-risk screening. This is what we are aiming at. We are not aiming at a population-based screening, because we know that in India, it's not going to work out. We are quite familiar with that. So we are not talking about population-based screening. We are talking about high-risk and opportunistic screening, which will go a long way in giving them a good relief and a comfort. Thank you.
Of course, right now I have a patient who has got a right breast T4, a Muslim lady around 55 years past postmenopausal. She has a disease in the right breast. She has opposite this thing also. His son has come down from Dubai and he is asking, nothing should be revealed to my mother. And he says, you hide and you chop off.
It's a very common thing in our Indian population, madam. There is
Yes.
no shared decision with the patient. And I think one of the slides I mentioned that it has to be a shared decision with the patient. It is often a shared decision with the relative. Right?
Relatives.
The relative will dictate what treatment you have to give, right? And so it's a big problem for us. So most of the time, some of the patients leave me in my consulting room and they walk out, because I would tell them that we need to tell at least some part of it to the patient,
Yes.
which they decline. So if the patient has got a metastatic disease, as I was telling you in certain instances, when we have to disclose this to the patient, it is a very important ethical consideration, because this guy may die leaving all his monetary benefits to somebody which he wouldn't have disclosed. So it is very important that this ethical consideration should also be there with the physician. I have seen people who have come from abroad, leaving all the money there with somebody whom they have trusted. And after they came here, found to have a metastatic disease, died within a month because the family did not want to disclose this. And all the money went waste, because the guy whom he entrusted the money with was not willing to share the money with the family. So these ethical considerations are very, very important, especially when an individual is suffering from a terminal illness. So terminal illness, it is the duty of the physician to tell the patient what he is suffering from. I know it takes a long time, but you have to disclose at least in part to the patient before you start the treatment, without which I don't think we are doing justice to our specialty.
Yes. Yes. That's what I told. And awesome.
Boss, overall, the people fall under the category high risk screening.
Sir, high risk screening, we have, say, for example, anybody who has a family history of breast cancers, ovarian cancers, correct? So that group will fall into the high risk screening group. And then we have a protocol which is laid down for people who have a body mass index which is very high, or who have any benign breast conditions in the breast, which they have reported earlier, like including mastalgia or any symptomatology relating to the breast. So we have a certain group of people, sir, but we advise all the people who come for an opportunistic screening, in the sense, whenever they reach the hospital for as an attender of one of the patients, then we advise them to have a screening done, because we know they fall into that family. So most of our patients who come and reach us for some other malignancy, we always tell the family that it is better that you have a mammogram done. And anybody above 50 years, it is preferable that they have a mammogram. So we know that the age in India is a little below 50, like 40 to 50. It is preferable in India, because you know the population to be screened in India is a little younger population. But whenever we see an opportunistic screening, we usually limit it to 50 years and above. And what we recommend is at least a clinical breast examination. As madam was telling, a clinical breast examination is far superior. In the Indian context, at least a clinical breast examination should be done, if not a mammogram. So we would recommend all people above 40 years to undergo a clinical breast examination. And this can be done even by a properly trained nurse, right? So this is what we need to really take up. So we need to train our nurses to do a proper clinical breast examination. And that itself will pick up a large number of disease. And when in doubt, always do a mammogram. So for example, you're examining a breast, you find something abnormal, then you need to do an imaging.
Hello, sir.
Yeah, tell me.
Good
Nivedana.
evening, sir. It's a very lovely thing, sir, to listen from the other side of the story. Just want to ask a thing. Are we taking this HPV vaccinations? I think it's the only viral preventable vaccines available. Are we taking it very seriously in other parts of sir? We are doing adult vaccinations here, sir, but most of the people is very difficult to convince them. Usually, when the college female or any MBBS students are visiting us, we used to do along with the HPV vaccination 016, we do the 3-dose vaccinations for them as a catch-up vaccination, sir. What's your experience and concern about it, sir? Thank you.
Right. See, we have been advising all the college. There are some lectures which we do in the colleges. So whenever we go to the colleges, we tell them about the importance of this vaccine. Correct. So, but the problem here is the monetary part. Correct. So it's not that everybody could afford it. So we know that the parents are a little anxious, because they are asking, why should we take a vaccine unnecessarily? And that is one question to be answered. And the other question is the financial thing. Now, there are some organizations like the NGOs who are coming forward to sponsor vaccines, correct? So they sponsor a particular batch of vaccines, correct? And that can be given with the help of the NGOs to colleges and schools. So this is our basic idea, but it has not worked up in a very big way, because no NGOs do this as a full-time measure. They are doing it in part in certain areas, correct, which are prevalent for them. But it has not picked up in a big way, because I think this should be brought into the school curriculum. Once you bring it into the school curriculum, then it will really work. So unless we bring this into the school curriculum, it's not going to work. You know, hepatitis B again is very important. So we need to our people should take hepatitis B as well, right? So hepatitis B vaccine again is very important, because especially among the doctors, right? So it's very important to take a hepatitis B vaccine as well. So
Sir,
I would say that we need to bring it to the school. I think Nivedan was asking whether how should we really implement it. We should really bring it to the school.
Now they brought the age to 9 to 14 years is the
9 to 14, yes, sir. I think we can have a good lecture by somebody on screening, like It's a
Yes,
very
yes.
good topic to be discussed.
Mm.
So
Because there are
screening
some
because
proponents.
often screening is overdone also, I feel. Like in many corporate hospitals, preventive health checkup, every year they are doing mammography in asymptomatic subjects with low risk.
Correct.
What do you think about that? Whether that radiation exposure is
That's wrong, sir. Like,
Sir,
that's why I said,
please.
like, for example, you do 3 mammograms and all the 3 mammograms are normal. You can do it once in 3 years. There is no standard indication to do it every year. But ultrasound is a good modality, sir. You can do ultrasound. There is nothing wrong in doing an ultrasound. And you know, the Japanese have a technique called octascan, where the individual can lie prone inside a water bath, and that will be done by an automated machine. I think now with the advent of AI, maybe you don't have to have a good sonologist as well. Maybe the AI would pick up much more lesions than the sonologist. So the sonology, the problem is it's operator dependent, and you need to place the probe correctly. Otherwise, you might miss out on lesions. And I think the technology will take over in a short while. I think we may get a lot of machines to do a very good scan with the help of an AI.
because
Previously,
in our practice, obesity, polycystic ovary syndrome, these are already patients who are more predisposed to CA breast. Add to
Yes.
that their late marriage, less number of pregnancies, less breastfeeding. So I think we are added too many risk factors in one go.
Sir, previously,
Infertility is another big problem, sir. Now you would have seen a lot of infertility people who come to us with breast cancers. We are seeing the rate of induction and the amount of IVF that they undergo. Some of them like 8, 10 in different hospitals. They skip one hospital to another, and they would have already undergone the threshold, but they keep going on and on, right? So that is another issue which is to be totally addressed. Like all these infertility clinics, we see a lot of people coming from infertility workups and people having breast cancers. And there's another
previously,
paper, sir, which is interesting, which says the BRCA people are usually infertile. That is another issue to be addressed, because they say that BRCA positive women are likely to be infertile as well.
Oh,
previously, Dr. Bose used to take being a woman itself is a
Yes.
high risk population. He used to how to screen, and after 35, it's better to have a screening. Whether it is what they spend for something else, they can spend it for an ultrasonogram, as he said, going to pick up.
Sir, one of the I mean, pertaining to the talk, one of the things that we have is communicating about survival to patients. Once you have made a diagnosis, then it becomes a matter of fact, how long do I have? It's a very dreaded question most of the time in all chronic illnesses. So, I mean, in specific areas, we don't have, guidelines. Most of the time, we depend on Western data to actually tell these people about the probability of survival and all that. So, in the cancer world, how does it work, sir? I mean, what do you rely upon? What is your yardstick to tell them about the probability of survival in different malignancies?
Correct. Now, the breaking the bad news, as you were rightly saying, is a big art. So we need to do it in multiple sessions. We can't do it in one session at all. I have seen people who will be very bold. They will say, Doctor, you tell me whatever it is, I'm willing to face it. But when you tell them that, your probability of survival for 5 years is 30%, they will swoon and they will fall down. And you have to resuscitate them sometimes. So this is a big art, in the sense you need to take multiple sessions to disclose this gradually to them. So we usually do it in stages. Like even when we see somebody coming to us with a PET scan showing multiple metastases, we just tell them, you await a biopsy report. Let us see what it is. And then I will let you know the next stage. And then when the biopsy report comes, then we tell them, right, let us try some chemo. We will see. So it has to be done in stages. It cannot be done at a single sitting. That is very important. And then nowadays, as you know, with the advent of all these media, people go and browse. They see everything. So they know most of the information before they come and meet you. So then you just put it across to him saying that it is not there in one particular area. It has gone to another area. So the probability of your survival will be less. Really, what I have noticed is when we do it in stages, they take it better. And the other thing is, you have to be really truthful to them. For example, if you ask me a pancreatic cancer, if a patient is going to ask me, what is my chances of survival? If he has got a metastasis, I would really tell him that it is almost nil, right? It will be hardly a few percentages. So I cannot say that few percentage and quote that few percentage with that immunotherapy or whatever it is and tell him that you are going to do better. No, I cannot do that. That is wrong. So I need to be truthful to him. So that is why I will tell him that if your percentage of survival is more than 30%, as per the literature, I would say that it is worthwhile treating you. If it is less than 30%, it is up to you to take the call. I won't recommend any treatment. So it is individualized. That is why I said the miracle to happen in a particular individual is not your option. You cannot say that miracles will happen. You can survive. So take this medication. You will live long for a miracle to happen. No, you have no justification to do that. As a scientific person, you need to consider pros and cons. You need to consider the financial toxicity of the individual as well. What is the point in giving some immunotherapy which has a few months of extended survival to a guy who is going to have multiple metastases all over his body? So you need to be very, very truthful to your patients. And I would say that any metastatic disease in a cancer which is not going to respond to chemotherapy, the survival is hardly 1 year. So this is what my teachers have taught me. So I would tell all individuals who are not responding to chemotherapy, who have very little chemotherapeutic benefit with metastatic disease, that you will survive for 1 year. And so it is the quality of life which I would guarantee for them. And so I would be really frank in expressing my opinion to them if they want a clear detail.
Yes, sir.
I think Nivedan shared some demographic school things. What is that, Nivedan?
Yes, sir. Actually, based on the 2011 census, sir, just calculated is the presentation I have made, sir, previously. But I think it is relevant to the discussion. It's school children, particularly to Tanjavur, Tamil Nadu and Tanjavur, the age of 9 to 14, sir. It's a primary target group for cervical cancer vaccination. Another thing is this missed out population, college-going girls. It is taken from the school data by UDASC and GER, sir. The conversion rate I have calculated. Just
what is the final inference, Nivedan?
Yes, sir. Actually, there are 20,000 female who have missed cervical cancer vaccination recently, sir, as it implemented. So government now is having a 32 crores budget being allotted this year for recruitment of HPV vaccinations. Sir. Mostly they are procuring the Cervavac vaccination, quadrivalent, sir. So 6, 11, 16, 18 only they are procuring, but they are not targeting this missed out population. I think this population is recently they are missed out, and some percentage need a catch-up vaccination. If any program is favoring that, that may be beneficial for the population, sir. I just want to share that thing.
No, I think why don't we make this as a patient-centric or an individual-centric program in the schools? See, we know that all children take vaccination, correct? So why can't we tell the parents that this is one among the vaccination which they should take? So why should the government take all the burden?
sir.
right?
So
So that is
this,
also one thing to be
this
considered.
IAP, I think, sir, this Association of Pediatrics has recommended this HPV vaccination along with as a part of adolescent vaccination. So they are recommending it. But I don't know about the mass vaccination strategy by the government, sir. Another thing is Sikkim government is implemented in their thing as a regular part of vaccination, sir. And one district among some MP or Rajasthan, I don't know, sir, they also have a pilot thing in doing it.
Correct.
Tamil Nadu government started in Viluppuram GH, sir. They have vaccinated last year, I think. It's been an article in Hindu. Viluppuram district, they have started vaccination. But this thing is under pipeline, sir.
Good. So I think more such programs should be done so that we would cover the entire population, and then awareness would come.
Sir, thank you so much, sir. Thank you, sir.
Thank you.
for-
Nice program, nice presentation. Thank you, sir.
Thank you, sir. Are there any further questions or comments from the audience?
Yes, sir, the screening is endless, as he said, to convince the patients. And that we have to motivate, we have to take it as a chance. I think being a lady, I have taken some more steps, just the advice of Bose. Anybody who comes, we are going to spend clinical breast examination only for a few minutes. That's a service. So, like that, as far as the breast and womanhood cancers, for that matter, anything, the family members, any of them are knowing whether it is a familial cancer or something, it's better to have a screening, annual screening or this thing.
What about teaching the society like CPR or BLS, breast examination also to the husband?
Yes, sir.
Sorry,
No, it's a very practical
Sir.
thing we
Yeah.
need to do, because when we are teaching a nurse, why not teach the husband about it? Right?
Yeah.
All right.
Sir, don't scold me.
It
Chief,
is an advanced stage.
you are very right, sir. Chief has a different knack of putting things. Right?
Yeah. Thank you both.
Thank you,
And
sir.
fantastic lecture.
Yes.
Thank you, Venkatesh.
I mean,
Thank you, sir. Thank you.
sir, we have to do much more like this. At least
Madam Ambuja,
the
madam.
news has to spread.
Right.
Being an October month, Bose has highlighted at least so many things about the cancers in the women. That matter, they suffer from anything.
No,
I
I think we
always
can come out
see
with
10 or
something
15
innovative,
people.
like our sir, Captain Sir has told. The men should take the initiative.
Yes.
Why not? So why not the men take the initiative to screen the women, right? So that's another good option, like Captain put it. So I think be something which is practical in India, right? Okay.
Sir, as you suggested, soon we will try and organize a talk on age-specific cancer screening for the general practitioner and for everyone in general. I think probably we'll organize one talk in the future, sir. It's a good suggestion and a great topic.
Sir, there are a lot of younger people also available, sir. We have to utilize them as well for the presentations. Like
Sure, sir.
this is a focused presentation, like what you're saying about screening. So focused presentations can be given for the younger people to take up and present, because they'll be presenting data also as well. So for
Sure,
example, Vedan is there, somebody is there, they can also present. It's not that, we should always have a senior person do it.
Yes,
We
sir.
always have the younger generation also to do some good talks,
Sure, sir.
which will be more centric towards data and things like that. It's very nice. Thank you, sir. Nice of you.
Thank you so much, sir. Thank you.
Thanks, everyone. Thank you.
I think with that, we will wind up. And I once again thank all our distinguished senior professors, Captain Sir, Ambuja Madam, for having graced the occasion and for a fantastic and a beautiful, much anticipated lecture from Professor Bose, sir. Thank you so much. Take care. Stay safe.
Yeah, we
Night,
are
sir.
honored to have him to have so much of thought-provoking ideas for screening and overall to participate, government, family, and the other people. There are a lot of things he has highlighted. Who used to bell the cat? Only ourselves.
Yes, ma'am. On that note, I think we will end the meeting, ma'am.
Yes.
Thank you so much.
Thank you.